Today, we're going to take a look at assessments and screening tools in CareManager. We're not going to go too in-depth in terms of reviewing every question on the comp or on the intake, for example. Instead, we're going to look more high level at the different ones that are in CareManager, when they need to be completed and or updated, and then some general functionality on how to kind of navigate through them in the system. So I'm here in the UAT. However, before we get to that, I want to point out on our resource page here, there's a section called Member Forms and Assessments. So all of the assessments and screening tools we'll be looking at today are available in paper copy here. So if you don't have your computer with you when you're doing one of these with your member, you can just enter them on paper and then data enter them later on. I'm also going to point out right here this assessment and screening tools document. This is a handy one right here. Kind of looks at just a quick guide of what's in CareManager and what's required, what's conditionally required, and if they need to be updated at all. So this is a good one to reference if you need some reminders on what's due when. Basically, the only ones you're going to need to do every year are your comp assessment and the SDOH. So we'll circle back to the UAT here, and we're going to start with the intake assessment. The intake is to be conducted at or around the time of enrollment. So in my new assessment tab, I'm just going to look for intake. Here it is. This is done at or around the time of enrollment to confirm appropriateness for the program. So as you know, there is a diagnostic eligibility that needs to be met to be in the program. Someone needs to have the single qualifier or 2 or more chronic conditions. However, in addition to that, we need to make sure that folks are also appropriate for services. Someone can have multiple chronic conditions, but be managing their care okay in the community. So this is how we make sure that we know that someone's needs rise to the level of health home care coordination services. One thing I want to point out on all of the assessments and screening tools we're going to look at today, when you open it up, it will default to today's date. So if you are data entering this from a couple of days ago, don't forget to backdate it to whatever date it is. For all of them, you'll have the option to leave them in draft. So if you are data entering it and get interrupted, if you are doing this with your member and they, you only get through part of it, you can enter as much as you have, save it in draft, and circle back to it later. The intake and the comp are set up in different sections. So we have the language culture, basic needs, etc. These are collapsible. So if you don't like to scroll for days and days and kind of want to make this more bite-sized pieces, you can collapse them all, and it just makes it a little bit cleaner and easier. The functionality is the same for all of the assessments. If I say yes to certain questions, other ones might highlight that make me fill in some more detailed information. If I say no, I can't read in my primary language, it's going to ask me what assisted, if I have someone to assist me. However, if I say yes, these questions will stay grayed out in the background and you don't need to do anything with them. There are several open-ended questions, such as this one that asks about cultural beliefs and customs. This is a very appropriate place to put in quotes. Whatever the member says, you can quote it directly right in here. I will say that New York State Department of Health does not like this as an answer, right? They look to make sure we are asking about cultural beliefs and customs. They don't like to see NA. They think everybody has a culture. They should have something. So, if your member doesn't say anything, you can put something in there, again, whatever they said. There are also other sections that are going to have things like this, where you're building out a table. So this asks who lives in the household. If there's no one else in the household, you simply go past this question and we know that there's no one else. If you need to add other additional family or friends, whoever might live there, you can keep adding rows for days, as many as you need to. If you click on this row by accident and you did 1 or 2 too many, just click the red X and they will disappear for you. The healthcare information section, this is a big one. I do want to point out a couple things in here. First of all is your current diagnosis. This is member reported. So this is another place where you might use quotes. It's another place where you're just going to write down whatever the member reports. This is not what is going to inform what goes into the problems tab in CareManager. What we put into the problems tab are what we're going to have verified records for, kind of proving that these are the current diagnoses. This is just simply what the member views to be their diagnoses. Sometimes it's interesting to see the difference between the two. Then you get into this big long question with all these providers here. And this is really intended to help you understand who are we going to have to help them connect to, right? Because that's going to be some of the first things we do, are some basic needs probably, and then getting them connected to providers. So if the member already has a PCP, I'll say they're currently connected. I can just write in the name of the PCP here. Last appointment and next appointment are required. These are not date fields though, so you can write in anything. And this might be another place to put quotes. Maybe they don't know exactly when they were there last. They just know it's been a long time. There's no appointment scheduled. You can just write that as well. So you'll go through the whole list here and fill them out. I want to point out too, so we have currently connected, provider needed, remember fused at intake, and NA. Oftentimes we see people putting NA for dental and optical, and New York State will ding us for that on audits because, to the best of their knowledge, all of our members have mouths and most of them have eyes. So maybe someone says, yeah, I haven't been to the dentist in years, but I'm just not interested in doing that right now. We can say, yep, they haven't been to a dentist, but they don't want one right now. So that's our way of noting that, yes, they don't have a dentist, but they're also we're not gonna be working to connect them with one. Same thing with optical. If they say, no, I don't really want to go to the eye doctor right now, I think I'm fine, member refused at intake. Where the NA might be appropriate is for, in this case, I have a male, he is not going to have or need an OBGYN. Maybe he has no legal involvement with probation and parole, so I can do that. No CPS or APS, those might all be good options for NA. If a member, needs a provider, maybe he does want to go get his eyes checked, then I'll just put provider needed. And then that will go in my plan of care as something we're going to work on. It's to get him connected to an eye doctor or whatever type of optometrist he might need. The legal section is fairly straightforward. This is just sort of current and past involvement, probation, parole, CPS, APS, etc. And the final section here is really just a drop down where you're going to pick the boxes here of what their appropriateness criteria is. These are exactly from New York State Department of Health. This is how they define appropriateness for our program. So as long as you check at least one of these boxes, someone would be appropriate for our program. If you find yourself saying, no, none of these apply, then we might not be enrolling this person into the program. So that is all that's in the intake assessment. I'm just going to cancel out of it for now. Again, this is going to be done at or around the time of enrollment to help you identify if this person is appropriate for the program, and also help you start to build your plan of care, thinking about what are the basic needs and what are the providers we're going to need to connect this person with once they are enrolled. The next one you're probably going to do is going to be your comprehensive. There's two in here. There's only one in the live. I'm going to pick comprehensive. That is due within 30 days of enrollment. And this is one that does get updated annually. Similar to the other one, I want to make sure I backdate it if I'm data entering, and I can save in draft or final. I get this question a lot. What's the difference between all of these? Well, initial is your first one. That's pretty obvious. Your initial is going to be initial. After that, don't get too hung up on what you put. You can put update for all of them. It's just your annual update. That's absolutely fine. Again, the sections all collapse, so you can do them one at a time. This is another one that's good for quotes. Anything we haven't talked about yet that you're worried about. Things like this, if I check they have a suicidal history, it's going to ask me to describe. And I can just write some notes about whatever they sort of report regarding that. Similarly, if I put in things like other here for assistive devices, I'm going to have to specify other. If I don't select other, I'm not going to have to answer any of those. The medications and hospitalizations are fairly straightforward, looking at barriers to taking medications. Do they understand them? Do they have questions for the doctors that we can help them get answers to? History of hospitalizations and ER uses. Long-term care is advanced directives. We are required by New York State to ask members about their advanced directive status and if they want more information on advanced directives. Our members are chronically ill, so it's important to have some of these, measures in place if they're interested. If we do have a yes to this question, would you like more information regarding it? We will expect to see this on your plan of care and something that you'll work on helping the member get more information on over time. We do, as an aside, on our website, have resources on advanced directives should you need them. Mental health and substance use are fairly straightforward. It's looking at current and previous instances of treatment and or use. In this one, there is a prompt right here to remind you that everybody gets the CAGE aid. So don't forget to do that for your first assessment. The HIV screening tools. For screening is just some basic questions about knowledge of HIV. If someone says that they wanted information or more information, we would expect to see that on the plan of care. There are also options in here, people have refused to answer some of these more personal questions. That's okay as well. Nicotine use is another one. If someone says that they want to quit smoking and we see a yes here, this should also be on the plan of care for sure. We definitely want to help people quitting smoking. Education and employment is just sort of current goals and past engagement with either one, if members have any. And the interpersonal relationships really gets at sort of safety. Do they feel safe where they live? Are they involved with DB providers? Do they have a caregiver if they need one? Benefits is just basic information about your benefits and how much they get per month. And last but not least is this summary section. This is 3 open-ended questions. It asks about strengths, weaknesses, and what's most important to you today, you being the member. And really, these are the first 3 kind of questions, if you will, on your plan of care as well. The plan of care asks for member strengths, it asks for member barriers, and it asks for an overall goal statement. So when we talk about the concept of the golden thread, that's the concept of taking information from the intake, from the other screening tools we're going to look at in a moment, and from this comprehensive assessment, and using it to inform the plan of care. This is your first step to that golden thread. We've already asked these questions, and now we're going to carry them right over to our plan of care, along with any other needs we've identified throughout this whole assessment process. So that is it for the comp. Again, this is one you are going to update annually. Once you save your first one and you go to open the next one next year, your answers from the first one will pull over, and they will do that every time. Your most recent responses will pull over to the next one. So you don't have to re-enter everything, but you do need to review this and you do need to update it. I can't tell you how often we see assessments where it's very clear that nothing was really updated, that things don't make sense in terms of dates. You say, yeah, it was 2 years ago back in, 2020, and it's like, well, that was 3 years ago now. So I can tell we can tell that folks haven't been updating them and really looking at them. So please make sure you're doing that. So intake, again, done at around the time of enrollment to ensure they're appropriate. The comp is done within 30 days of enrollment and then annually thereafter, and that information will pull over for you. The one that we had the prompt for in the comp was the CAGE aid. That's this one right here. This is a very simple 4 questions about substance use. We are required by New York State to ask about this. That's why it's in here. It's simple 4 questions. Again, it doesn't take long to do. And it is really intended just to get at if someone has an issue with substance use, that we can maybe talk to them about it and hopefully help them get into treatment if needed. This, again, is going to be done around the time of intake. You can do it with the intake, you can do it with the comp, you can do it closer to the plan of care. It doesn't really matter, again, as long as we're doing it and using that information to pull into the plan. It does not have to be updated annually. However, the purpose of these screening tools that we're going to be looking at is that they are here and they are standalone so that you can use them at any time. If I had a concern about someone and their use, maybe I think their behaviors are changing or they smell like alcohol more often, maybe I want to kind of ask these questions in a sort of nonchalant way. You don't have to say, we should do the CAGE aid right now, but just ask these 4 basic questions and will help you get a sense of sort of where they are. Going back to our resource page really quickly here, we have the screening tool guidance document, which I have open right here. And this goes through all of our screening tools. This is the same kind of matrix we looked at in the other one, but it tells you how to score them too. So for the CAGE aid, if you answer yes, you get a 1. And basically, if you have an answer, a total score of 2 or greater, then it's considered clinically significant, and it might be appropriate to talk to this member about perhaps pursuing some substance abuse treatment. So again, the purpose of these screening tools is really to be screening and screening for referrals needed to potential providers. So again, this will be done, sometime before your first plan of care. It does not have to be done again, but if you have concerns, it is here for you to pull out and use whenever you feel it is necessary. The next one we're going to look at is the MMS, the Modified Mini Screen. This is a little bit longer. It's the longest of the screening tools, but it also doesn't get used that often. Another requirement of New York State Department of Health is that we are screening people for the potential of a mental health disorder or condition that we might need to refer them to a provider for. So this is getting at just that. You only need to use this, though, for folks who don't have a mental health diagnosis, right? If someone comes in with a diagnosis of bipolar, schizophrenia, we do not need to do this. We know that they have a mental health disorder, right? We don't need to screen for that. Similarly, if you have someone who comes in and they are already in mental health counseling or they're in some sort of therapy, we also don't need to screen because that's what the clinician or therapist is doing. So this is really just for your folks who come in who are purely medical. We do not have a lot of them. So again, this doesn't need to be used that often. Like I said, it is a little bit longer. It's 22 questions. It is broken out into sections, so you can kind of do one at a time and save them in draft if needed. It takes probably about 15 minutes to complete altogether. And then back in our screening tool guidance, the next one here will kind of tell you how you can score it. So if it's a 6 or greater, so yes to 6 or more questions, it's the likely presence of a psychiatric disorder. Particular attention should be paid to question 4 because that would indicate concerns for suicidality. So again, this one is not used a lot, but if you have folks who are not connected to any behavioral health services and there's no history of behavioral health diagnoses or services, this is when we would want to kind of screen for that, again, so that we can refer them out to a provider if there is a concern. The last one in this list here is the CSSRS. This is the suicide screening, the Columbia Suicide Severity Rating Scale. This is not required. It is used when and if you are concerned about a member and their potential to harm themselves or, make an attempt on their life. Again, it is up to 6 questions. There's a few hidden now. If you say yes to 2, the other 3 populate. So it's a total of only 6 questions. Again, they are things that you can ask in a conversational format, not make the member feel they're being assessed if you are concerned. The nice thing about this one and why we picked this one specifically is it is used quite frequently. If you had a concern about someone and asked them some of these questions, and then you called mobile crisis or their clinician or whomever and said, hey, I just did the CSSRS, and they said yes to 4 out of the 6, that person will more than likely know what you were talking about and know what next steps need to be taken. If you are concerned that someone is at imminent risk, you do not have to use this. The call to mobile crisis might be just appropriate, but again, it is in here to kind of gauge the level of concern. Going back again to our guidance tool, there is also information on how to score that one here. So please take a look at that and make sure you understand the results and what the next steps might need to be. So those are the screening tools in here. Again, we looked at the intake and the comp. Comp is done annually. The CareManager, which everybody's going to get, but they only have to get it once. The MMS for folks who are not connected to and don't have a history of any behavioral health or mental health concerns or treatment. And then your CSSRS, which we just looked at for concerns about suicidality, which is completely optional. The last one does not live in the assessments tab. It's down here on its own under new forms, and that is the SDOH screening. Eventually, I believe all of our assessments move down to this new form as NetSmart is updating some things, but for now, the SDOH stands alone. This is also required by New York State. These questions specifically are dictated by New York State. This one does have to be done annually. On your action boards, you will see it kind of tied to the plan of care. It's time to update your SDOH and your plan. However, you can do it with the comp. You can do it between your comp update and your plan update. Again, anytime in there with the idea, again, of that golden thread that we're taking the information we glean through all of these screening tools, all of these assessments, and using it to inform our plan of care. Again, this one is dictated by New York State. It's 10 questions. It's pretty straightforward, and it just talks about basic SDOH needs. It talks about the member's home environment, food insecurities, transportation, utilities, and then it talks about some safety in terms of interpersonal relationship kind of safety. So again, this one will be done annually, and it will be, again, done sometime between your comp and your plan update. The idea that when you're doing these updated assessments and screening tools, you're using that information to feed it into your plan of care update. So that's a quick overview of all of the assessments and screening tools in CareManager. Again, please look at our resource page for paper copies of any of these, as well as the quick guide of what's due when, and the screening tool guidance, which will help you understand how to interpret and what some best next steps would be after you complete those screening tools with your members.